And you were talking about anesthesiology, and our next speaker is a specialist in that area. Dr. Sanjay Acharya is president of Queensway Carleton Hospital's Medical Staff Association. He's also an active member of the Department of Anesthesia and the Department of Clinical Care Medicine at the hospital. He was born in Newfoundland, spent his youth and obtained his early education there, and then came to Ontario to practice with the military. He's a Canadian Armed Forces medical officer who has served for 21 years in uniform. Please welcome Dr. Sanjay Acharya.
Thank you very much. The check's in the mail for that chair. That's fantastic.
I have to say, I don't know how many stories to tell or what stories to tell. I thought about this before I came. I thought about this sitting down. And I realized I'm just going to get up and start talking and figure it out as we go along. So I think I'll start by, most people here may have had some experience with surgery. Maybe they haven't, maybe they know somebody. So I'll talk about anesthesia. We break it down into three areas. Your preoperative assessment, what we do for you during the operation, what we do for you after the operation. There's no question that the cuts that have been in place and the cuts that are proposed are going to affect that. When you look at how I look after you before you have an operation, I gather information to plan a safe anesthetic so that you wake up at the end of it and go home happy. To get that information, I have to speak to your family physician. I have to get consultant reports from maybe a cardiologist. I have to get diagnostic imaging from a radiologist. These are the key areas that the government has affected in terms of funding, therefore affected the access that you have to them, the access that I have to them, and the access that I have to get the test done. That's just the preoperative part. During the surgery, the different types of surgeries that we do, the different ways that the government has decided to fund them, the different formulas that bureaucrats put in place, they've altered what it is that they want to drive business to. So it's not really based on what the public needs. It's not based on what we think is appropriate care. It's based on what the government's willing to fund and how much they're willing to fund it. Because that's what they say to you. They say, you're allowed to do these things, we'll pay for those. You're not allowed to do these things, we don't pay for that. And post-operatively, they've taken money out of pain management. They've taken money out of acute and chronic pain management. So after your surgery, the access to that care is going to be affected. So that's just one small piece of how anesthesia is going to be affected for you in this current setup the government's put in place. When I look at the cuts, there's no question. I think everybody has to understand that there's not enough money. The government has less money. The physicians are going to get less money, and the patients are going to get some less care. But to make that sustainable, safe, effective, and to deliver the best care that we can afford, takes input from everybody. And the government, we all feel, has acted unilaterally, irresponsibly, without input and guidance, as some of my previous panelists have said, on the presumption that everything we're doing is only in our self-interest. Look, I was a family doc before I became an emerg doc. I was an emerg doc before I became an anesthesia and intensive care physician. All I do all day long is look after people. Sometimes I do it well, sometimes I'm not so happy. I try and make them as happy as I can, safely and effectively. The way the government is setting up this business is making it harder and harder. I sit on the board of directors of the hospital, and the government is changing the way that our hospitals are funded. It's outside the purview of this talk, but it's very salient. They're going to a case-based model of funding. They're taking the average cost of all cases across the province, saying this is what the average cost is. We're now going to fund that case at 40% of that average cost, with the intention to drive the high-cost people out of business and to encourage the low-cost people to keep doing the business. This is for hospitals, not for individual care. But I've cracked the government code. Anytime they say we want more efficiency, we want to reap some of the technological efficiencies, we want efficient care, what that is code for is cheap. And that's okay. We want our tax dollars to be utilized well. We don't want $1 billion wasted on Orange and $2 billion on e-health. Nobody wants that. We do want them used well. But as physicians, our other job is to make sure those dollars are used effectively, safely, with the best evidence. And the government doesn't have that in place. You know, I talked to the negotiations people on our side, and I was fortunate enough to have done a year-long master's certificate course with somebody from the government. And it's very apparent to me, nobody trusts anybody. The government doesn't trust the doctors. They think we're ripping them off. The doctors don't trust the government. We think they're hiding all our money from them. And the patients don't know what to think at the end of the day. Who's telling the truth? How does this work? There's a gap in the knowledge. I mean, I'm in business, and I didn't understand half of what some of these guys said about tests and stuff like that. This technological knowledge is so fine and so in-depth that you can only trust the people that do it all the time, because otherwise you don't know anything about it. And that's the part that the government's missing. I think that we need to demand that everybody be represented at the table. You need input from physicians to say, hey, this is the best care. This is what you should have. This is what we think you should have. This is what it's going to cost. And the government looks at that and they have a representative to say, okay, this is where we are willing to put that money. This is the money we have. This is what we can spend. And then however the public's interest and the patient's interests are represented, they say, this is where we choose to put our healthcare money. It's your healthcare system. It's not mine. It's not the government's. It's how you get your care. And you talk about going back in time to 20 or 30 years ago. My uncle's a family physician in rural Newfoundland, and he started practice just at the change when the Canada Health Act was sort of coming into effect. Those things were coming around. And back then, the whole issue of care was really simple. People came along, they got looked after, and it was really a local initiative. There wasn't an overarching thing to tell people what they could and couldn't do, and it was really community-driven, community-based, and people got the care that they could get at the time. Times have changed now. We're a lot smarter than we were. We have a lot more knowledge. We have a lot more technology. People have a lot more expectations, and we can deliver a lot more. Your Dr. Misnick say, patient 1 of 175,000 is alive. That's amazing. We can do that. We can do it cost-effectively. We can do it safely and sort of effectively, but we need the government to accept input from everybody, not act unilaterally and irresponsibly. Thank you.